Let me invite Dr. Ramone Torne to share his clinical decision-making indication for the patient and selection for treatment.
So can you open, please, my presentation? First, thank you to invite me. It's a pleasure to be here. And so I will talk about MMA embolization, about the clinical decision and the indication of patient selection for treatment. So the last 3 years were very interesting in treatment of chronic subdural hematomas. Has appeared the big trials. The big trials changed a lot during, almost in the States and in other countries. But if you look what is happening in Europe, the things are not changing so much. You see that in the most of the European university centers still treating the patients as they do like 5 or 10 years ago. So we are not really implementing the new evidence that appear. It is new fantastic tool that it seems that is the embolization of MMA in chronic subdural hematomas. And this is for different reasons. One of the reasons is because we are more focused maybe in other pathologies, the costs, and also for we are not focusing protocolize and try to get all the information we get through these studies and try to protocolize in our own environments. So, and decide what to do. So that's what we tried to do like 3 years ago with my colleagues in my hospital. So we try to protocolize the way we treat chronic subdural hematomas to provide the best evidence and to provide to our patients the best results at that moment. So, and we decide to do it taking in account our context. So we cannot do the things that are people in the United States are do embolization in most of the patients. So we have, because it's not cost effectively and there are some gaps in evidence. So we want to be focused in the patients that really the embolization will be a benefit for them. So we decide to select 2 groups. The first groups will be the symptomatic groups, these patients that have come with some hemiparesia and some major deficits, and the other group will be the asymptomatics and paucisymptomatics. So in the symptomatics group, we also divide the patients if they have low or high recurrence, and if the patients have 2 or more of these items of high recurrences, we decide to do a combined embolization. We do both things. We do surgery and we do an MMA embolization. So the items we review in the literature and also in the evidence that have a high risk of recurrences are very known for all of us. So coagulopathy, nitated thrombotics, high volume of hematoma, membranes, for example, or recurrence, or the age. We know atrophy is also related to recurrence. This is one of the groups, and the other group that will be, we think that can benefit from MMA as a fair protocol, will be the patients with a volume of more than, a diameter for more than 10 millimeters that are asymptomatic or paucisymptomatic. Dara has spoke before about this. There are patients that sometimes have a headache, have some minor symptoms. So we thought that these patients could also benefit from this statement. So here is our increase of numbers. So we started really in 2024. In 2023, we only did 3 patients. In 2024, we did a little bit more, and last year we did like 23 patients. So in my hospital, I come from a hospital, big hospital in Spain. It's 1.5 million of reference, more or less, but it's not it's a medium hospital if you are taking in some hospitals in Europe. So we treat mostly 70 something out of 70, 80 subdurals per year. So it's something like 30% of the subdurals now goes to endovascular treatment. So half of them goes to endovascular alone, and the other half of them, that will be the pausosymptomatic or asymptomatic patients, and the other go to endovascular and surgical treatment. Most of them, we try to do the endovascular and the surgical treatment at the same stage, one stand-alone treatment at the same moment, but for logistic reasons, we cannot do in all of them. So in some patients, we do first the surgery, at the day after we do the embolization. So if we do only the endovascular treatment, we do in angiosuite. The protocol is similar to doing an aneurysm or doing a stent, so it's easy. The angiosuite, the workflow, it's more in the O-arm, in the hybrid O-arm, the workflow it's a little bit more complex. So here we are doing an embolization of MMA. So we decided to start doing the endovascular procedure first, so not to alter the anatomy of the MMA. And then after we do heparin, and then after, when we finish the embolization, we reverse the heparin and we do the burr hole. We do always with general anesthesia. So we follow these principles. We try to do radial access if it's possible. We think most of these patients are anticoagulated or have some antithrombotics, so this want to help us to have less complication. We do ipsilateral embolization, not bilateral per se. So we have discussed before also with Dara, because at that moment the literature, the interpretation of the literature we did at that moment, we decided to do like this, but we are not sure about that. And we try to go distal and to do all the branches, to do frontal and parental branches and go as distal as possible. So our goal is the efficacy should not compromise safety. So which technique we use? We started with liquids, with squid, normally squid 12, and we have changed during these 2 years a little bit our techniques. We started using a Septer mini balloon. We do it a lot of patients with Septer mini balloon. Septer mini balloon is a very good device, so we can achieve a very good penetration, and we reduce a lot the time. But we have some problem with Septer mini balloon. We have some ruptures of the MMA, some asymptomatic ruptures, intradurally ruptures, that it's like a fistula. They did like a fistula in the veins that surround the MMA, and that it's easy to solve with some more squid or some coils or maybe a little bit of glue. So, and also we do embolization, distal embolization with Sonic or Marathon or whatever microcatheter you normally use to do an embolization. And only we did one case with the new Penumbra coils, but we are not sure we will continue, we will see, because we want to penetrate and go as distal as we can with the treatment. So, and here you have our cohort of patients. So surprisingly for me, the age is relatively low, 76 years. Look that most of the patients have some kind of anticoagulation or antiaggregation. So it's a normal thing in these patients we have been treated. So the ranking score is good, previous to the subdural. So, and as our protocol, most of the patients as primary subdurals, not recurrences. Here are our safety outcomes, the things. So we saw in 4 patients dangerous anatomical variants. In most cases, if we see the dangerous anatomical, we try to go, and we can go distal and we can do the embolization safely, we continue with it. If not, then we abort the procedure. And the major complication we have is the rupture of MMA. So because we use the septal mini balloon. So none of these patients have symptoms of this. We can completely block the branch. But it's something it happens different times. And we thought that it's because maybe it's a branch that is more easily to be ruptured at some point. And it's something you have to keep in mind if you use septal mini balloon. The other thing that happens with osteocord is a catheter related that is stuck, and that's one of the major complications and need a carotid stenting. And here are our clinical results. Or clinical achievements or radiological achievements. Most of the procedure time is relatively, it's about 2 hours. Now it's a little bit less. The degree of embolization we get, it's satisfactory. It's good. It's more than 50–75% of MMA. We get also in most of the patients a distal penetration, and we get also in most of the patients parietal and frontal embolizations. Here are the radiological outcomes. We have been talking about this before. We see that if we do a CT at 6 weeks, that is part of our protocol, we see that some of them, 23% of them have some remnant, some important remnant. We have been talking about this before, but if we follow these patients at 6 months, we see that the remnant reduce a lot, so only to 9% of them. We need to treat these 2 patients surgically finally, because the remnant is important. And if you see the clinical outcome, it happens something similar. If happens something similar. So if when the follow-up is at 3 weeks, we see that there is still some patients with not good clinical outcome. But if we follow at 6 months, we see 80% of the patients had a good ranking coma scale. Here is our cohort related to the other big trials. You see that our recurrence is a little bit higher, for example, if you compare to MAGIC or Embolize, because I think our cohort is not so big. And if we see the complications are very similar, we have 1 death for pneumonia, but it's really not clearly related with the procedure, but it's in the first days after the treatment. And we have also a stroke. But it was something in advance. We see in the last, when we do the angiography at the finished part, and we do a thrombectomy, and the patient goes well without any symptoms. So I think it's applicable. So I think MMA embolization, it's applicable, but has some problems. Need logistic, need a cost effectivity study, and need to be integrated in your environment, because it's not the same environment that we have in some countries, that the environment that they have in the countries that do the trials. There are remaining challenges that I think that are very interesting. One is the difference between radiological outcome and clinical outcome. We see sometimes a not so good radiological outcome, but a very, very satisfactory clinical outcome. The other thing is how we really follow up these patients clinically. We follow with ranking score. I don't think it's a good scale. Probably in the future we will need cognitive scales, that it's important. Nobody is talking about that, but 30% of these patients at 1 year have a dementia, new dementia. So we have to study this. Maybe there are some secondary brain injury that are not focused on, we're looking only at the subdural or neurological deficits. The other thing is the patient selection. We need to study more risk factors. The optimal strategy we have been talking about. And of course, the follow-up. I think to say that a patient is completely cured, you need to wait until 6 months. And of course, cost effectiveness explorations. Thank you very much.
Thank you for your presentation. Are there any questions, comments?
Thank you so much, Ramone. Nice to see you building up the experience quite fast. Would you agree that the major trials that come out, that the absolute risk reduction is very little as compared to before these trials occurred? Retrospective series meta-analysis reported on a decrease, absolute decrease of 15%, 16%.
Yeah.
That would translate in a number needed to treat of 5 to 6. But now this is also an issue in the implementation. This has also raised some skepticism about the whole treatment.
Yeah.
You mentioned as well. What do you think is the main driver that before the trials came out, we were very, it was very promising with absolute risk reduction of 15, 16%, and then with the trials is more like 4 to 6%?
Yeah, I don't know. I don't know. I think the trials are focused in a different patients we are selecting now. So the trials are different. So we are focused in big trials that are done in states, different population. And we are more focused, for example, you said that in asymptomatic patients that have some headaches, that these patients are, in some cases, not entering in a trial in a stage, right? So we are focused in a different populations, and that's important. And the other thing, I think also there is a certain skepticism in the societies, no, to introduce because same results in another pathology, it's a successful, right? And in this it's like, no, but it's not enough, right? It's not. I don't know. I think we keep working on that. We keep study that. We generate more knowledge to finally try to select these patients that really will benefit from this.
Thank you.
Some other comments? Okay, then we can continue with Dr. Boogarts with his presentation. You're welcome.
So, good afternoon. So thank you for the organizing committee for the opportunity to present for this wonderful congress. So the role of endovascular therapy in AVM treatment. So basically endovascular therapy is one of the cornerstones of AVM treatment next to surgery, of course, and stereotactic radiosurgery. However, there are serious limitations in terms of efficacy and procedural risks. So what are the indications for embolization and AVM treatment? So what if we look into the literature, and of course there are a lot of retrospective series, but if we look into the more high quality literature, what are the risks of endovascular treatment? And actually there are two main studies. One is the TOBA study, which is a registry, prospective registry, but also a nested trial. You can read it. But so one of the core findings on surgery, of course, is that it's very effective. But if we dive into the results of endovascular therapy, we see that so they divided those AVMs in which there was an intention to cure, and those AVMs in which it was only like a pre-treatment to surgery. And what if you see into the low-grade intention to cure, there only the real achieved cure is only 1/3. Or not only that, but also the risk of complications is 1 in 5, so that's relatively high. And if you look into the post-treatment deterioration, also this is very high, 1 in 5 almost. And in the overall serious adverse events, so periprocedural and delayed, also there's a high risk of complications. So the only acceptable is if it's like a pre-treatment to other treatment, and that's the lowest risk. So what's the other high quality study in which patients are prospectively enrolled before the treatment? So one is the TATEM trial, which compares the transarterial versus transvenous treatment. And this is not about the transvenous treatment, but so the primary outcome was the occlusion, and transvenous was far more effective than transarterial. But if we go into the complications of treatment, we see that even in the in the transvenous, it's 1 in 3 has procedural complication, but also in the transarterial group, so only transarterial, also more than 1 in 3 has complications. So we see that in high quality studies in the current era, there's a high risk of complications of endovascular treatment for AVMs. So we should balance our complications versus our results, and it's all about planning and strategy. So what is the role in the current era of endovascular treatment? So I'll go systematically over. So associated aneurysm, that's of course quite easy. If we have in this case a cerebellar ruptured, in this case the aneurysm was ruptured, the patient came with a suprarenal hemorrhage, the AVM itself was not ruptured, and there was a pica aneurysm, as you can see here, and of course that's easy. So just coil it. So also in this case, the patient with a 64-year-old female with a rupture came in due to this aneurysm of this lenticular striate. So just selectively catheterize and embolize this. So, and don't touch the AVM because it's a very complex one with high risks of treatment. So, what are the other options? Intranidal aneurysms. This is a patient who came in with an intraventricular hemorrhage with also thalamic region on the left side. And here you see the small aneurysm, which is sometimes difficult to discern whether it's venous, really venous, or arterial aneurysm. Anyhow, this is the location of the bleeding, and you should go selectively for this and embolize it. So I didn't put the whole run, but it's also in the more venous phase, this aneurysm is obliterated. Here's another case with an intraparenchymal but also intraventricular extension of a hemorrhage in this 20-year-old patient. And then you see the culprit of the bleeding is this extension, which could either be venous or also arterial, which is not quite clear. Here you see the lateral image and the pre and post embolization. So selectively go for the target and don't treat the entire AVM in the acute session, because you risk too much. So what's next? So the deep small, which is a little bit similar. So here's a posterior choroidal, small feeder. Go selectively for this, and you can able to occlude this because also the alternative surgically is not that attractive. So then complete obliteration. It's the same case as I showed you before because of the pica aneurysm. This is one case you always have to identify, are there acceptable feeders for extensive embolization, or even is there a possibility to go additionally transvenous to accomplish a complete obliteration. So make the plan on forehand and not be surprised during the procedure, or don't change that much your plans. Also, if there's a small, of course, they're very suitable. Here you see a small from the superior cerebellar artery, which are very suitable for embolization. So, but if you go for complete embolization, always check in the long term. And we dived into literature in our own series, and actually literature is not that well described. Actually, there are only a few series who describe the results, the angiographic results on the long term. So typically there's the first primary DSA is done, and based on this, it's called occlusion or not. And in the follow-up, often non-invasive imaging is done. But as we know, there are limitations in terms of sensitivity and specificity of the non-invasive imaging on determining the risk or the presence of recurrence. And so we looked into those studies and our own results in the long term in the second DSA, so secondary follow-up. And we see that there is also a risk, if it is initially completely obliterated, that it reoccurs after a long time, even after 5 years. So take that into account in your follow-up. So pre-surgery, yeah, of course, obvious. That's also seen in the TOBAS study. It's so the least risk group, and sometimes very effective, sometimes very helpful. This patient with the bleeding on the left side, and you see here the parietal AVM. And so the target of embolization is not to treat the entire AVM because of the pedicles are not suitable to do so. But then you have to target on this part of the AVM, which is in terms of surgery the most difficult and which is the most deeply seated. So you go for the deeply seated part of the AVM, you see here, to tackle this lower part. And then if you go to surgery, this is very easy surgery. It's like a kind of meningioma. It's very well boundaries and it's very nice to do. And otherwise, those deep-seated feeders are surgically mostly the most difficult ones because you always have to chase them all the way down, and those vessels aren't normal, so you just cannot coagulate it as you do with normal vessels. So it's very helpful. So microsurgery and preoperative, there's a lot said about this, and in this extensive review, what they found is that there's no difference if you do preoperative embolization compared to direct surgery. No difference in terms of obliteration, complications, worse MRS of mortality. So, should we do it? Should we not? It's not significant. However, if you look a little bit more into the numbers, there seems to be a higher risk of complications if you add embolization to the microsurgical group, which is not a surprise. It's not statistically significant. There's a lot instead about this meta-analysis. There's a kind of bias in the groups because those who are embolized before, there's a kind of reason to embolize them. So it's not out there the definite answer. It can be used as an adjunct, but be selective. So these were the conclusions. So if it's really not needed, then don't. So finally, prior embolization, prior to stereotactic radiosurgery, well, in generally we say no, don't, because if we do embolization prior to stereotactic, it's less effective. Also, this study has kind of bias because of the volume which they took into account to compare the groups, but there are substantial evidence that it is not as effective. So, giving these results, there are people who say you should do both, but first gamma knife and then directly followed by embolization, which is a kind of new strategy which could be implemented to increase efficacy, like a dual treatment in the short time, but the other way around. Hopefully we'll see more on this new strategy in the future. So what's your blueprint to success? It's a systematic approach, actually. It's the clear indication, the timing, what to treat of the AVM, the treatment modality, of course, and it's all about also judging the imaging. So take your time. Don't be quick. Don't say, well, it's easy, because it's not. So make a drawing of the AVM. You're forced to see what are the pedicles, what are the draining veins. It really makes you comprehend the AVM. And it's not easy. It's always, at least for me, it's not easy. It's always more complicated than you think. So don't simplify. Look at the angioarchitecture and look at the exact location. So, and what holds true for the results in literature doesn't mean it's your result. So look at your own results, evaluate your own results. Now in the Netherlands, we are going to start a compulsory database of all the treated AVM. So every treated AVM in the Netherlands should be registered in this database. And hopefully we'll get more reliable results in the near future and can compare also between centers, because there's a lot of heterogeneity, which is good, but it's also nice to study which is the optimal treatment. Having said this, thank you very much for your kind attention. Happy to take any questions.
Thank you, Dr. Boogarts, for this beautiful review. And think twice before touching every single AVM. Are there any comments or questions? Thank you.